Imagine you are a medical detective, sort of a, I don't know, a Medlock Holmes, and you've just been summoned to investigate what is basically the greatest, most devastating, completely unsolved epidemic in modern psychiatry.
Oh, I like this. Okay, set the scene.
Right, but here's the bizarre twist to this particular case. Unlike all the previous mysteries you've investigated, there is absolutely no mystery about what the murder weapon is.
It's just sitting right there.
Exactly, it's hiding in plain sight. I mean, what if the exact tool you are allowing your patient with schizophrenia to use, just to stay calm on the inpatient ward, the very substance you're just turning a blind eye to in the clinic, is the exact same tool guaranteeing they will die 25 years before you do?
Which is a terrifying thought for any clinician.
It really is. The evidence of its lethality has been overwhelming. It's documented, completely irrefutable for decades now.
Yeah.
I mean, the crime scene is literally littered with the proof. Yet millions of people just continue to willingly pick up the weapon. So the mystery for our detective is not what the substance does. The real clinical puzzle that we have to solve today is why. Why humanity continues to just willingly step into this trap, knowing exactly what the consequences are.
Well, to solve that puzzle, we really have to begin exactly where every psychiatrist must begin. We have to ground ourselves in, I suppose, the foundational anchor of our field.
Right, which is what?
Psychiatry is, at its very core, the study of how the brain, the mind, and human experience all interact with one another. And crucially, how that intricate process can just go terribly wrong.
Yeah, that makes sense.
So when we look at addiction, particularly the profound dependence we're discussing today, we're basically witnessing a systemic hijacking of that exact interaction. It's a complete biopsychosocial collapse.
Well, welcome to this deep dive. Today, we're taking you with us as we really unpack Kaplan and Sadok's comprehensive textbook of psychiatry. Specifically, we're zooming in on Chapter 11.8 on tobacco-related disorders.
The vital chapter.
It is. And if you are a trainee, maybe a registrar, a clinician, or honestly just someone fascinated by the vulnerabilities of the human mind, think of this conversation as a sort of conceptual companion to the text. We are not here to just recite a list of statistics at you or, regurgitate diagnostic criteria.
No, that wouldn't be very helpful.
Right. Our mission is to build robust mental models together. We want to clarify the underlying mechanisms, strengthen your clinical reasoning, and fundamentally change how psychiatrists approach what is, arguably, the deadliest psychiatric disorder in existence.
And I think it's an essential mission because historically speaking, the psychiatric profession has suffered from a profound blind spot regarding this entire topic.
A massive blind spot.
Absolutely.
Yeah.
There has been this pervasive tendency to view tobacco use as a secondary, lifestyle issue, just a habit, rather than a primary, severe, and incredibly complex psychiatric disorder that actually demands rigorous clinical intervention.
And that blind spot, that's exactly why I found myself visualizing nicotine as like the ultimate neurological Trojan horse as I was reading through this chapter.
Oh, Trojan horse. I like that analogy.
Yeah, because patients believe they are just adopting a habit, right? They're bringing this little wooden statue into the gates of their city to help them, I don't know, manage daily stress or alleviate boredom.
Right. Harmless coping.
Exactly. But what they, and honestly, often their clinicians fail to realize is that once the substance is inside, it fundamentally rewires the city's entire infrastructure from the inside out. It's sabotaging the cellular machinery.
It really is. It's a Trojan horse that doesn't just invade. It actively alters the blueprints of the city itself. It forces the host's own architects to essentially build more gates, specifically designed to let more of the invading force in.
Wow, build more gates.
Yeah, that is the biological reality of this invasion. And I think to understand the true scale of the devastation, we must first look at the epidemiology, because the burden of this epidemic is, quite frankly, not shared equally at all.
Let's examine that unequal burden. Because the general public narrative, the one we hear all the time, is that we have essentially won the war on smoking.
You hear the public health success stories constantly.
You do. The general adult smoking rate in places like the U.S. has dropped to, around 14%. We have Clean Air Acts, we've got smoking bans in pubs and public spaces, heavy taxation. It feels like a massive victory.
It sounds like a victory, yes, until you pivot your focus to mental health and addiction treatment settings.
And then what happens?
When you step onto a psychiatric ward or into a dual diagnosis clinic, those public health victories just vanish. Depending on the specific population and the severity of the psychiatric illness, between 50% and 95% of patients in these clinical settings smoke.
Wait, I'm sorry, 50 to 95%.
Yes.
That is not a margin of error. That is an entirely parallel reality. I was looking at the breakdown in the text, and it seems the prevalence scales with the severity of the illness, doesn't it?
It does.
So patients with, say, major depressive disorder might sit at the lower end of that elevated spectrum. But those with schizophrenia or bipolar disorder, they push right towards that absolute maximum.
Precisely spot on. And the consumption volume is equally staggering. Individuals with mental illness and substance use disorders consume 44% of all cigarettes sold in the U.S.
44%.
Nearly half of the entire tobacco market is being consumed by this one specific, highly vulnerable demographic.
That is just wild.
They aren't just smoking more frequently either. They're smoking more heavily, they're extracting more nicotine per cigarette, and they suffer from far, far lower quit rates than the general population.
Okay, so we have this incredibly concentrated burden. What does this actually mean for the patients on a systemic level? I mean, when a patient with severe mental illness dies prematurely, what is actually killing them?
Well, the primary thief of their time is not their psychiatric diagnosis. People with severe mental illness die, on average, 25 years earlier than the general population.
25 years.
A quarter of a century. And while, yes, suicide and accidents do contribute to that mortality gap, the overwhelming drivers are tobacco-related illnesses.
Like what, specifically?
Cardiovascular disease, respiratory illnesses like COPD, and various malignancies. The psychiatric illness is just what places them in this highly targeted demographic. But the tobacco is the weapon that ultimately takes their life.
You use the word targeted there, and I think we really need to linger on that for a moment. Because this disparity, it wasn't some tragic accident of nature. The tobacco industry didn't just stumble into this demographic by chance.
No, they certainly did not.
The textbook dives into the Legacy Tobacco Documents Library, which contains these internal industry memos that surfaced during litigation. And the level of calculated exploitation is chilling.
It's completely unethical.
I mean, R.J. Reynolds literally had a strategic term for this. They called it the downscale market profile.
Yeah, the internal communications reveal an industry that was meticulously studying populations that were homeless, institutionalized, or severely mentally ill. They referred to these individuals in their documents as more impressionable, less formed intellectually, and explicitly, quote, more malleable.
More malleable. That's just sick.
They identified a population burdened by neurological vulnerabilities, social isolation, and institutional dependence, and they exploited those exact factors with surgical precision.
And they actively manufactured a narrative that eventually infiltrated the clinical mindset itself. They fabricated what the textbook describes as the self-medication hypothesis.
Oh, yes, a very persistent myth.
They ran these advertising campaigns directly targeting people with mental illness, essentially implying that smoking was a perfectly normal, necessary part of managing their condition. There was this one advertisement cited that read, "Schizophrenic, for new merit, having two sides is just normal behavior."
Unbelievable.
They were explicitly telling these patients, you are broken and you need this product to function in society.
And they ensured the product was inescapable within the very institutions meant to heal these patients. The industry supplied free or heavily discounted or even tax-free cigarettes to psychiatric hospitals for decades.
To the hospitals themselves.
Oh, absolutely. They lobbied aggressively to ensure that smoking was permitted inside psychiatric facilities long after general medical hospitals had gone entirely smoke-free. Cigarettes practically became the de facto currency on psychiatric wards.
Like a literal currency?
Yes, used by staff to reward compliance or manage patient behavior. They wove the Trojan horse into the very fabric of psychiatric care, basically making the addiction completely indistinguishable from the treatment environment.
Okay, I have to challenge this narrative just slightly, though. Because we can't lay all the blame at the feet of tobacco industry marketing executives, right? Didn't the medical establishment, psychiatrists, nurses, hospital administrators, didn't they perpetuate this too?
Sadly, yes.
My understanding is that a significant portion of clinicians genuinely believe that patients needed to smoke to prevent psychiatric decompensation.
And that right there is the great misconception in psychiatry. It represents a profound failure of clinical reasoning. There was a tremendous amount of minimization and rationalization by clinicians, driven by a combination of fear and just a fundamental misunderstanding of addiction neurobiology.
Tell me more about that fear.
Well, the textbook highlights a very revealing survey from 2007 conducted by the American Association of Medical Colleges. They surveyed over 3,000 physicians regarding their attitudes towards smoking cessation.
And what did they find?
47% of the psychiatrists surveyed reported feeling that their patients had, quote, more immediate problems to address than their tobacco use.
It's the classic triage fallacy. Let's stabilize the acute psychosis or the suicidal ideation first, and we can worry about their pulmonary health a decade from now.
Exactly. It completely compartmentalizes the patient. But the survey revealed an even more damaging belief. 22% of psychiatrists reported believing that initiating smoking cessation would actually heighten their patients' other psychiatric symptoms.
Wait, they thought quitting would make the mental illness worse?
Yes. They harbored a genuine clinical fear that if they took away the cigarettes, the patient's underlying schizophrenia or bipolar disorder or severe anxiety would just spiral completely out of control.
Well, I suppose if you are a well-meaning clinician and you genuinely believe that removing a substance will precipitate a psychotic break or a severe depressive episode, of course you're going to turn a blind eye. You might even facilitate the smoking.
Exactly. First, do no harm, right?
Right. So what is the actual clinical truth then? When we look at the data objectively, what really happens to the mental state of a psychiatric patient who quits smoking?
The clinical truth completely dismantles that great misconception. The textbook relies heavily on a landmark 2014 systematic review and meta-analysis conducted by Taylor and colleagues.
Okay, Taylor et al.
This was a massive undertaking. They examined 26 longitudinal smoking cessation studies. They tracked patients before they quit and then followed them for months afterward. And the findings were unequivocal.
Which were?
Quitting smoking leads to a significant sustained decrease in anxiety, a decrease in depression, a decrease in psychological stress, and marked improvements in overall mood and quality of life.
Wow. So the deeply entrenched idea that cigarettes serve as this crucial pharmacological crutch for long-term mental stability is just unequivocally false.
It is worse than false. It is an absolute inversion of reality. Now, obviously, we must acknowledge the clinical reality of the acute withdrawal phase.
Right, the short-term effects.
Yes, the first 2 to 4 weeks of smoking cessation can be highly challenging. Patients will experience irritability, dysphoria, anxiety. However, once they navigate that acute neurochemical adjustment period, their baseline mental status has not worsened.
It actually improves.
Significantly. In fact, the Taylor meta-analysis demonstrated that the psychological benefits of quitting smoking are equal to or even greater than the benefits of initiating a course of antidepressant treatment for mood and anxiety disorders.
That is an incredible statistic, equal to an antidepressant.
Exactly. Patients with psychiatric comorbidities who successfully quit maintain stable mental health, they vastly improve their physiological health, they reclaim their financial resources, and, crucially, they often require lower dosages of their psychotropic medications.
We are absolutely going to deep dive into that medication dosage point later because the hepatic mechanisms behind that interaction are just brilliant, and they're vital for any prescribing clinician to understand.
They really are.
But before we explore the clinical manifestations and the specific treatments, we really need to take our detective's magnifying glass to the etiology. We need to understand the structural trap. Let's look at the neurobiology. How does this chemical actually hijack the central nervous system?
Right. So the hijacking begins at the microscopic level, specifically at the ligand-gated ion channels. Nicotine is an alkaloid, and it essentially mimics the endogenous neurotransmitter acetylcholine.
Okay, acetylcholine.
Yes, it binds to and activates nicotinic acetylcholine receptors, which are distributed extensively throughout the central and peripheral nervous systems. However, the specific receptors we are most concerned with regarding the reinforcing and addictive properties of nicotine are the alpha-4 beta-2 and the alpha-7 receptor subtypes.
So alpha-4 beta-2 and alpha-7. I was trying to map this out conceptually while reading, and, the standard analogy of a lock and a key just felt insufficient here.
Yeah.
Because this isn't just about unlocking a door.
No, it's far more aggressive than that.
Yeah, I was reading about how these receptors react, and it reminded me more of a distributed denial of service, a DDoS attack on an IT network.
Oh, explain that.
Well, normally acetylcholine binds to the receptor, it transmits a brief signal, and then it detaches, allowing the system to reset, right? But nicotine just floods the system. It binds to those alpha-4 beta-2 receptors, opens the ion channel to let the sodium and calcium rush in, but then it lingers. The receptors become completely overwhelmed and they undergo a conformational change into a desensitized state. They basically shut down and become unresponsive to further stimulation. So the brain, which is monitoring this network, senses a catastrophic drop in functional receptors.
That is a highly accurate conceptual model. It's a biological paradox that frequently trips up clinicians, actually.
How so?
Well, generally in pharmacology, if you chronically flood a system with an agonist, meaning a drug that stimulates a receptor, the brain responds by downregulating. It removes receptors to try and dampen the overwhelming signal and maintain homeostasis.
Right, to turn the volume down.
Exactly. But with nicotine, because those alpha-4 beta-2 receptors desensitize so rapidly and profoundly, the brain's homeostatic feedback loop is completely tricked. The brain essentially thinks, I have no functional acetylcholine receptors available, I must build more to survive.
So it deploys more servers, so to speak, to handle the perceived lack of signal. It initiates receptor upregulation.
Exactly. Chronic nicotine exposure leads to a massive proliferation in the sheer number of nicotinic receptors in the brain. And this upregulation is the fundamental physiological driver of tolerance and profound physical dependence.
Okay, so what happens when you stop smoking then?
When the nicotine levels in the blood begin to drop, which happens very quickly, the desensitized receptors begin to wake up. So now you have millions of newly built, empty, hungry receptors demanding to be fed.
Oh, wow.
If they're not immediately supplied with nicotine, they trigger a cascade of neurochemical distress. So the smoker's no longer smoking to achieve a high, they're smoking simply to silence the millions of receptors screaming for homeostasis.
And what specific brain circuits are these receptors actually communicating with? Because the trap involves both a reward that pulls you in and a punishment that prevents you from leaving.
Right. The neurocircuitry involved two primary opposing pathways. The reward pathway, the pull, is centered in the mesolimbic system. When nicotine binds to receptors in the ventral tegmental area, or VTA, it stimulates the release of dopamine and glutamate into the nucleus accumbens and the prefrontal cortex.
Dopamine is the big one, right?
Yes. This pathway is the universal language of survival and reward in the mammalian brain. It creates the sensation of pleasure, increased attention, cognitive enhancement. It basically tells the brain, whatever you just did, it is vital for your survival, so do it again.
Okay, so that is the dopamine carrot. What is the stick?
The stick is the withdrawal circuitry, which is modulated by entirely different neurotransmitters and anatomical structures. When nicotine levels fall and those upregulated receptors begin demanding activation, it triggers the release of glutamate and corticotropin releasing factor, or CRF, in the habenula interpeduncular axis.
Wait, so the habenula?
Yes. The habenula acts as an anti-reward center. When it's stimulated by nicotine withdrawal, it actively suppresses dopamine release in the VTA and triggers the profound irritability, anxiety, anhedonia, and physical discomfort that characterize withdrawal.
So the patient is caught in a literal neurobiological vice. The VTA is promising a dopamine reward if they smoke, while the habenula is delivering crushing anxiety if they don't.
Exactly. A perfectly engineered trap.
And the delivery system for this chemical, the traditional combustible cigarette, makes this trap terrifyingly efficient. Let's discuss the pharmacokinetics, because the substance itself is only half the story. The method of delivery is what makes it so inescapable.
You're absolutely right. The modern combustible cigarette is, without hyperbole, one of the most highly engineered, efficient drug delivery devices ever created by human industry.
How does it work so fast?
When a patient inhales tobacco smoke, the vaporized nicotine is drawn deep into the alveoli of the lungs. From there, it is absorbed directly into the pulmonary venous circulation and pumped straight into the arterial system via the left ventricle of the heart. Crucially, this route completely bypasses the liver's first-pass metabolism, which would normally filter and break down a significant portion of an ingested toxin.
So by bypassing the liver, it means it has a direct, unobstructed highway straight to the brain. I think the text notes it reaches the central nervous system in less than 15 seconds.
10 to 15 seconds. That is faster than the delivery time of an intravenous injection of heroin.
Faster than high-V heroin. That's terrifying.
The brain receives a concentrated rapid spike of nicotine that perfectly hits those VTA receptors, providing an instant dopamine surge. However, nicotine has a relatively short half-life of roughly 2 hours.
So it's gone quickly.
Blood levels peak quickly and fall quickly. This rapid kinetic profile, the fast onset and the steep decline, is what drives the relentless, cyclical need to redose constantly throughout the day, just to avoid the habenula's withdrawal punishment.
But there is another pharmacokinetic feature that makes nicotine uniquely insidious compared to other addictive substances, and that is the lack of intoxication.
Right. Very important point.
If we think about severe alcohol or opioid use disorder, the substance fundamentally impairs the user's ability to function in the world.
Exactly. Intoxication inherently limits the frequency of use. If someone consumes large amounts of alcohol or heroin, they become incapacitated. They can't drive, they can't operate machinery, they can't hold a coherent conversation. Their drug administration is naturally bottlenecked by their own impairment.
But nicotine?
Nicotine causes no such behavioral impairment. A patient can smoke while driving a car at 70 miles an hour, while typing a report at their desk, while drinking a coffee, or while talking to their children. There is zero behavioral interference.
Which basically allows the drug administration to seamlessly integrate into every single aspect of the patient's daily life.
Completely integrated.
Which brings us to the psychological component of the trap, right? The classical conditioning. The textbook provides a mathematical breakdown of this that really illustrates the scale of the problem clinicians face.
The numbers are staggering.
They are. If a patient takes 10 puffs per cigarette and they smoke a pack of 20 cigarettes a day, they are delivering 200 distinct rapid-fire doses of nicotine to their brain every single day. If they maintain that habit for 20 years, that results in roughly 1.5 million conditioned drug self-administrations.
Over 1 million repetitions of a deeply reinforcing behavior. Every single one of those puffs pairs a rapid dopamine spike in the VTA with whatever environmental cue the patient is experiencing at that exact moment.
So like having a coffee.
Yes. The smell of morning coffee, the tactile sensation of gripping a steering wheel, the emotional state of feeling stressed after a phone call, or just the physical sensation of finishing a meal. Through basic Pavlovian principles, these neutral environmental cues become inextricably linked to the neurochemical reward.
So eventually, just getting in the car triggers a craving.
Exactly. Eventually, the cue itself, just sitting in the car, is enough to trigger a massive craving, entirely independent of actual biological withdrawal.
So as a clinician, you are not just fighting the half-life of a chemical or the upregulation of alpha-4 beta-2 receptors. You are fighting 1.5 million repetitions of classical conditioning.
You're fighting an ingrained identity.
You are fighting a neurological association that is woven into the very fabric of the patient's identity and daily routine. And the sources suggest that not everyone enters this trap with the same baseline vulnerability. Let's look at the genetic and environmental precursors. Are some individuals biologically predestined to get caught faster and deeper?
Well, the initiation, the severity of dependence, and the likelihood of successful cessation are all highly heritable traits. The genetic landscape is quite complex, but one of the most clinically relevant examples involves the CYP2A6 gene.
CYP2A6. Okay.
This gene codes for the primary hepatic enzyme responsible for metabolizing and clearing nicotine from the body. Individuals possess different variants of this gene, which dictate whether they are slow, normal, or fast metabolizers of nicotine.
Okay, so if you are a fast metabolizer, your liver clears the nicotine much more rapidly, meaning your blood levels drop faster, plunging you into withdrawal more quickly. Is that right?
Precisely. Fast metabolizers experience the negative reinforcement of withdrawal much sooner after their last cigarette. Consequently, they are biologically driven to smoke more cigarettes per day, to inhale more deeply, and to smoke earlier in the morning just to maintain a baseline level of comfort.
That's incredibly unfair.
It is. This genetic variant directly increases their risk of severe dependence and makes cessation significantly more difficult.
And we cannot discuss vulnerability without addressing the environmental and developmental factors. The text notes that 90% of all adults with tobacco use disorder initiated their smoking before the age of 18.
Adolescence is the critical window of vulnerability. The adolescent brain is undergoing massive structural reorganization, particularly in the prefrontal cortex, which governs impulse control and decision-making, and the limbic system, which governs emotion and reward.
So adding nicotine to that mix.
Exposing this developing neurocircuitry to exogenous nicotine permanently alters the trajectory of brain development, leading to long-lasting deficits in attention and an increased susceptibility to other substance use disorders later in life.
It also intersects heavily with trauma, right? The textbook highlights the profound impact of adverse childhood experiences, or ACEs.
The correlation is undeniable. Children who experience multiple ACEs, such as physical or emotional abuse, neglect, or severe household dysfunction, are at a significantly heightened risk for early initiation of tobacco use.
Why is that?
Well, smoking becomes a highly accessible, rapid-acting, pharmacological coping mechanism for a profoundly dysregulated nervous system. They are using nicotine to self-soothe traumatic stress long before they have the cognitive maturity to comprehend the lifelong addiction they are cementing into their neurobiology.
It is a devastating reality. You have a 14-year-old trying to calm a traumatized nervous system, and by the time they are 20, they have accrued millions of conditioned responses telling them this chemical is their only reliable survival tool.
Exactly.
So we understand the trap, the neurobiology, and the vulnerabilities. But if the brain is structurally rewiring itself this aggressively for nicotine, it really explains why patients are so desperate to find loopholes.
Oh, they constantly look for loopholes.
They attempt to outsmart the system by switching delivery methods. They tell their clinician, I don't smoke cigarettes anymore. I just use a hookah on the weekends. Or I've switched to vaping, so I'm safe now.
I hear that every single day.
Right. So does changing the delivery method actually change the underlying neurobiology? Or is this just the same trap painted a different color? Let's move into the clinical manifestations and examine these alternative products.
It is largely the exact same trap. And in many clinical scenarios, the alternative products introduce entirely new, poorly understood dangers, often exacerbated by the patient's false sense of security.
Let's break that down.
Let's systematically break down the data provided in the textbook. We can begin with cigars and cigarillos. The prevalent public misconception is that cigars are significantly less harmful because users typically do not inhale the smoke deeply into their lungs, they just hold it in the mouth.
Right, the assumption being that if it doesn't hit the alveoli, it doesn't cause systemic damage or severe addiction.
Which is biologically false. The nicotine in cigar smoke is readily absorbed through the buccal mucosa, the lining of the mouth. But the critical issue is the sheer volume of the drug.
How much are we talking about?
A standard combustible cigarette contains roughly 6 to 11 milligrams of nicotine, delivering perhaps 1 to 2 milligrams systemically to the user. A single typical cigar, however, can contain anywhere between 100 and 200 milligrams of nicotine.
Wait.
And some premium large cigars can contain up to 444 milligrams.
444 milligrams in a single product. That is an astronomical exposure.
It is massive. Even without deep inhalation, the systemic absorption can lead to profound dependence. Furthermore, cigar smokers are exposed to the same toxic, carcinogenic combustion byproducts, leaving them highly susceptible to oral, esophageal, laryngeal, and lung cancers.
Okay, what about water pipes, commonly known as hookahs? There is this pervasive cultural myth, particularly among young adults, that drawing the tobacco smoke through a basin of water somehow filters out the toxins and renders the practice harmless.
Yes, the idea that the water purifies the smoke is entirely fallacious. The water cools the smoke, which makes it less harsh on the throat, allowing the user to inhale more deeply and for a much longer duration.
Right, a session can last a long time.
A typical hookah session can last an hour, involving hundreds of inhalations. Research demonstrates that hookah smoke delivers significant quantities of nicotine, but more alarmingly, it can deliver vastly higher levels of carbon monoxide, heavy metals, and tar compared to smoking a traditional cigarette. And the charcoal used to heat the tobacco introduces its own severe toxicological profile.
What about smokeless tobacco products? Chewing tobacco, snuff, or snus. These entirely bypass the combustion process and the lungs, which is often how they are marketed as safer alternatives.
Smokeless tobacco does eliminate the respiratory hazards of smoke inhalation, but it provides a uniquely intense pharmacokinetic profile. Because it is absorbed through the oral mucosa, the peak nicotine concentration in the blood is delayed compared to a cigarette. It might take 30 minutes to reach maximum levels.
But then it stays high.
Exactly. The delivery is continuous and prolonged, providing high levels of nicotine for up to 60 minutes after the product is removed from the mouth. To contextualize the concentration, one single standard can of dip or chewing tobacco contains approximately 144 milligrams of nicotine.
144?
That is the nicotine equivalent of roughly 4 entire packs of cigarettes packed into a single tin. It causes profound dependence, significant dental and periodontal disease, and greatly elevates the risk of oral cancers.
And then we arrive at the most complex and rapidly shifting frontier, NDS, electronic nicotine delivery systems, universally known as e-cigarettes or vapes.
This represents a massive regulatory and clinical challenge. E-cigarettes are aggressively marketed, often implicitly, as safe alternatives or cessation aids. However, the textbook stresses the profound dearth of rigorous, long-term clinical research regarding their safety profile. What we do know is that the nicotine concentrations in e-liquids vary wildly, typically ranging from 6 to 24 milligrams per milliliter.
And the chemical formulation of that nicotine has evolved too, hasn't it? We're no longer just dealing with free-base nicotine, we are dealing with nicotine salts.
Yes, the introduction of nicotine salts fundamentally altered the landscape. Nicotine salts lower the pH of the inhaled vapor. This allows manufacturers to deliver incredibly high concentrations of nicotine, levels that would be unendurably harsh and painful to inhale in a free-base form with exceptional smoothness.
So it doesn't hurt your throat.
It completely removes the physiological friction of inhaling a massive dose of a stimulant.
Which makes it terrifyingly appealing to adolescents who might otherwise be repelled by the harshness of a combustible cigarette.
Precisely. It facilitates rapid, deep inhalation of high-concentration nicotine, accelerating the development of dependence in a developing brain. Furthermore, the aerosol is not, quote, harmless water vapor.
What's actually in it?
The e-liquids contain solvents like propylene glycol and vegetable glycerin, along with thousands of chemical flavorings. When these substances are heated via the device's atomizer, they undergo thermal degradation, producing known toxic aldehydes and heavy metals. We also cannot discuss NDS without referencing the severe acute risks highlighted by the 2019 EVALI outbreak.
EVALI being e-cigarette or vaping, product use-associated lung injury. There were over 2,000 hospitalizations and numerous deaths. Now, my understanding is that the CDC primarily linked that specific outbreak to vitamin E acetate, an additive predominantly found in illicit or black market THC vaping cartridges, rather than standard commercial nicotine vapes. Is that right?
That is correct. The vitamin E acetate in THC products was the primary culprit for that specific wave of acute lung injury. However, the clinical takeaway for psychiatrists is that the NDS market is incredibly poorly regulated.
We just don't know enough.
The long-term pulmonary effects of inhaling aerosolized propylene glycol and complex flavoring compounds deep into the alveoli daily for decades are completely unknown. Switching from a combustible cigarette to a vape is not a cure for tobacco use disorder. It is simply a substitution of delivery systems, often maintaining the exact same upregulated receptor demand and the exact same behavioral conditioning.
Given all these different products and manifestations, how does the field actually categorize the pathology now? The DSM has evolved over the years. We used to talk about abuse versus dependence. How does the DSM-5 codify this trap?
The DSM-5 streamlined the diagnostic approach by abandoning the arbitrary distinction between abuse and dependence entirely. Instead, it offers a single, unified diagnosis, tobacco use disorder or TUD.
And how is that assessed?
It evaluates the pathology based on 11 specific criteria that span 4 domains: impaired control, social impairment, risky use, and pharmacological indicators, namely tolerance and withdrawal.
And it evaluates the severity on a spectrum based on how many criteria the patient meets, correct?
Yes. Meeting 2 to 3 criteria indicates a mild disorder, 4 to 5 indicates moderate, and 6 or more criteria indicates severe tobacco use disorder. This spectrum approach allows clinicians to better tailor their interventions based on the precise level of impairment the patient is experiencing.
Let's focus on the withdrawal criteria for a moment, because if we are going to assist patients through cessation, we need to know precisely what physiological and psychological symptoms they are going to endure.
The tobacco withdrawal syndrome is highly predictable. Symptoms typically onset within 24 hours of abrupt cessation or significant reduction in use. The DSM-5 criteria include depressed mood, insomnia, which is often characterized by increased awakenings, and remarkably vivid, intense dreams.
Vivid dreams?
Yes, very common. Also irritability, frustration, anger, anxiety, difficulty concentrating, restlessness, and increased appetite.
I look at that list of criteria: insomnia, irritability, severe anxiety, depressed mood, poor concentration. And I realize this perfectly mimics the exact symptomatology of the primary psychiatric disorders we were trying to treat in the first place.
It does. It overlaps heavily.
Right. So a patient with generalized anxiety disorder quits smoking, experiences these withdrawal symptoms, and immediately concludes, my anxiety disorder is relaxing, I need a cigarette to manage my mental health. How does a clinician parse that?
It requires meticulous clinical tracking and patient education. The clinician must preemptively educate the patient that these symptoms are a temporary neurochemical artifact of withdrawal, not a permanent deterioration of their mental state.
The timeline is key then.
The timeline is critical. These withdrawal symptoms typically peak between the first and third day of cessation and gradually subside over 2 to 3 weeks. although cue-induced cravings can persist for months or even years. If the severe anxiety or depressed mood persists beyond a month of verified abstinence, the clinician must then reevaluate the underlying psychiatric diagnosis.
Interestingly, the textbook notes that the DSM-5 actually removed two criteria that were present in the older DSM-IV for nicotine withdrawal: reduced heart rate and weight gain. Why were they removed? I mean, it is a universally acknowledged clinical reality that people often gain weight when they quit smoking, and their resting heart rate certainly decreases once the stimulant is removed.
They are absolute physiological realities, you're right. However, the diagnostic manual relies on predictive validity. Extensive research demonstrated that experiencing a reduced heart rate or gaining weight had absolutely no predictive value regarding whether a patient would successfully maintain their smoking cessation or relapse.
So they didn't predict the outcome.
Right. They are physiological facts, but clinically they do not drive the pathology or predict the outcome of a quit attempt in the way that intense craving, anxiety, or depression do. Therefore, to increase the clinical utility of the diagnosis, they were removed from the formal criteria.
This brings us to a scenario that, for my money, represents the most critical piece of clinical reasoning in this entire textbook chapter for a prescribing psychiatrist. I want to present a hypothetical clinical situation based on the pharmacology detailed in the text.
Okay, let's hear it.
Imagine you are a psychiatrist on an inpatient ward. You have a patient with treatment-resistant schizophrenia who has been stable on a specific dose of antipsychotic medication for several years. They are a heavy smoker. While on the ward, they decide to make a serious quit attempt, and they succeed. The smoke clears. A week later, you examine the patient, and they look horrific.
Not good.
No. They are experiencing severe akathisia. They cannot stop pacing. They are profoundly sedated. They are drooling, and they appear highly toxic. The immediate assumption for many clinicians would be, oh, the stress of nicotine withdrawal has caused their schizophrenia to decompensate, and I need to increase their antipsychotic dose. What is actually happening here?
Increasing their antipsychotic dose in that moment could be catastrophic. What you are witnessing is not a psychiatric relapse, and it is not simple nicotine withdrawal. You're witnessing severe medication toxicity, driven by a profound, often overlooked hepatic mechanism.
Let us unpack this mechanism very carefully. How does the act of stopping smoking cause a patient to become toxic on a medication dose they have tolerated for years?
The mechanism hinges on the hepatic cytochrome P450 enzyme system, specifically the 1A2 isoenzyme, or CYP1A2. When a patient smokes combustible tobacco, the polycyclic aromatic hydrocarbons, the carcinogenic chemicals present in the tar and the smoke itself, not the nicotine.
Right, the smoke, not the nicotine.
Exactly. These chemicals act as powerful chronic inducers of this CYP1A2 enzyme in the liver.
So the toxic byproducts of combustion are constantly revving up the liver's metabolic engine, basically forcing it to process certain chemicals much faster than a normal liver would.
Exactly. The liver is in a state of hypermetabolism. Therefore, for a heavy smoker to achieve a therapeutic blood plasma level of any medication that is primarily metabolized by CYP1A2, the psychiatrist must prescribe a significantly higher dose than they would for a non-smoker. The liver is just chewing through the drug so rapidly that you have to flood the system just to reach a therapeutic baseline.
And which critical psychiatric medications are metabolized by this specific CYP1A2 pathway?
The most crucial ones in psychiatric practice are clozapine and olanzapine, two incredibly potent antipsychotics, as well as the antidepressant fluvoxamine and the typical antipsychotic haloperidol.
So we return to our clinical scenario. The patient abruptly quits smoking. The polycyclic aromatic hydrocarbons are no longer entering the system. What happens to the liver's engine?
The induction abruptly ceases. Without the constant presence of the smoke, the CYP1A2 enzymatic activity rapidly downregulates, returning to a normal, much slower baseline metabolism within a few days.
But they're still on the same drug dose.
Exactly. If the psychiatrist has not proactively anticipated this and preemptively reduced the medication dose, the patient is now taking a massive hypermetabolic smoker's dose of clozapine, but processing it with a normal, slower liver.
The drug begins to rapidly accumulate in the bloodstream. The textbook states that the blood plasma levels of these medications can spike by 30 to 40% almost immediately after cessation.
Yes, a 40% sudden increase in clozapine levels will precipitate profound toxicity. It will cause severe sedation, hypersalivation, severe extrapyramidal symptoms like the akathisia you mentioned, And crucially, it drastically lowers the seizure threshold, potentially causing life-threatening convulsions.
Which perfectly mimics a psychiatric episode.
Exactly. The clinical presentation perfectly mimics a severe psychiatric deterioration or an acute neurological event, but it is entirely driven by the sudden cessation of tobacco smoke.
That is an astonishing demonstration of why psychiatrists must understand the systemic physiological interactions of addiction. But the chapter details one other substance heavily affected by this exact CYP1A2 drop that I thought was absolutely brilliant because it explains so much unnecessary suffering during quit attempts. Caffeine.
Yes, this is a vital, everyday clinical pearl. Caffeine is also primarily metabolized by the CYP1A2 enzyme.
So consider the typical heavy smoker. They often consume massive amounts of coffee because their induced liver is clearing the caffeine so rapidly that they need 6 or 7 cups a day just to feel the stimulant effect.
Exactly. They have built a caffeine habit predicated on a hyperfunctioning liver. When they quit smoking, the CYP1A2 activity drops, but the patient almost always continues to drink their usual 6 cups of coffee, often leaning on the coffee even more to cope with the oral fixation and the fatigue of nicotine withdrawal.
So their liver stops clearing the caffeine accumulates.
Their blood caffeine levels skyrocket, often doubling within a few days despite no change in intake. The patient rapidly develops severe caffeine intoxication,
Which manifests as profound agitation, tachycardia, severe anxiety, jitteriness, and absolute insomnia. And what does severe caffeine intoxication perfectly mimic?
It perfectly mimics the most severe manifestations of acute nicotine withdrawal. The patient is sitting there, vibrating with anxiety, unable to sleep, thinking, I am having the worst nicotine withdrawal imaginable. My brain cannot handle this. I'm going to lose my mind if I don't smoke.
When really?
In reality, their actual nicotine withdrawal might be relatively mild. They are simply overdosing on their morning coffee because their liver has slowed down.
That is the epitome of clinical reasoning right there.
Yeah.
If a psychiatrist or a primary care physician guides a patient through smoking cessation, they must monitor and preemptively reduce the dosages of clozapine and olanzapine. And they must explicitly instruct the patient to cut their daily caffeine intake by at least half.
It's essential advice.
That single piece of advice, managing the caffeine toxicity, could be the difference between a successful long-term quit attempt and a traumatic relapse. Understanding these mechanisms allows us to intervene effectively. Let us transition to those interventions. How do we actually guide a patient out of this highly engineered, neurologically entrenched trap? The textbook outlines a universal standard of care for clinical intervention known as the 5 A's approach. This isn't just a checklist, is it? It's a framework for navigating the friction of treating addiction. Walk us through how a clinician should implement this.
The 5 A's approach: ask, advise, assess, assist, and arrange. It provides a structured, evidence-based pathway for every clinical encounter. It forces the clinician to confront the issue systematically, removing the temptation to just ignore the tobacco use in favor of more pressing psychiatric symptoms.
Okay, step 1.
The first step is ask. The clinician must systematically screen every single patient for tobacco use at every visit and formally document the status. It cannot be an afterthought. In some clinics, they utilize a carbon monoxide breath monitor during the intake.
Which moves the addiction from a subjective questionnaire into a concrete, objective biological metric right there in the office.
Exactly. Step 2 is advice.
And this is where I imagine significant clinical friction occurs, especially with highly agitated or treatment-resistant patients.
It does. The clinician must advise the patient to quit using a clear, strong, and highly personalized message. You must tie the advice directly to the patient's specific health status, their finances, or their family. Crucially, for the psychiatric population, the clinician must explicitly state their clinical belief that the patient can quit.
Why is that so important?
Because of the legacy of the Great Misconception. Many of these patients have been implicitly or explicitly told by previous doctors that they are incapable of quitting or that their mental health will shatter if they try. The psychiatrist simply affirming, you have a severe illness, but I believe recovery from this addiction is possible for you, and it will improve your mental health. That is a profound, often unprecedented therapeutic intervention.
You are dismantling the self-medication myth directly to their face. Okay, step 3 is assess. You are gauging their readiness to change.
Right. You assess their willingness to make a quit attempt at this specific moment. Are they in the pre-contemplation stage, or are they ready to take action within the next 30 days?
Which dictates step 4, assist.
If the patient is not ready to quit, your assistance involves motivational interviewing, exploring their ambivalence, highlighting the discrepancy between their smoking and their life goals without lecturing them. If they are ready, you help them construct a concrete quit plan.
What does that look like?
You identify their specific environmental triggers, provide behavioral counseling, and most importantly, you offer and prescribe evidence-based pharmacotherapy.
And step 5 is arrange.
Arrange follow-up contact. Tobacco use disorder is a chronic relapsing condition. You do not just prescribe a patch and wish them luck. You schedule a follow-up visit or phone call within the first week of their quit date to monitor for withdrawal, manage medication side effects, adjust psychiatric dosages due to the CYP1A2 shift, and provide relentless psychological support.
Let us deeply explore the assist phase, specifically the pharmacotherapy, because relying solely on behavioral willpower, just white-knuckling through the upregulated receptor demand, has abysmal success rates. The data clearly shows that deploying pharmacological tools essentially doubles the probability of long-term abstinence.
Pharmacotherapy is the cornerstone of effective treatment. The FDA has approved 7 distinct first-line medications for smoking cessation. 5 of these fall under the umbrella of nicotine replacement therapies, or NRTs.
These are the familiar products, the transdermal patches, the nicotine gum, the lozenges, the oral inhalers, and the nasal sprays. The clinical logic here is elegant. You are providing the brain with the precise exogenous chemical it is screaming for, the nicotine, to stave off the severe withdrawal of the habenula pathway.
Exactly.
But you are delivering it without the thousands of toxic carcinogenic byproducts of combustion, and crucially, without the rapid 15-second pharmacokinetic spike that triggers the intense dopaminergic reward in the VTA.
That's the key. NRTs decouple the physiological chemical dependence from the behavioral, classical conditioning of smoking a cigarette. A transdermal patch provides a slow, steady, baseline level of nicotine over 24 hours, preventing the deep troughs of withdrawal.
And the shorter-acting ones.
Short-acting NRTs, like the gum or lozenge, can be used dynamically by the patient to manage acute cue-induced cravings. Combining a long-acting patch with a short-acting gum is often the most effective NRT strategy.
But the textbook also details 2 highly sophisticated, non-nicotine prescription medications that alter the underlying neurochemistry directly. Let's examine bupropion first. I notice it's not just a cessation aid, it is fundamentally an atypical antidepressant.
Yes, bupropion was originally developed, and is widely used, as an antidepressant. Its mechanism of action is distinct. It acts as a relatively weak inhibitor of the neuronal reuptake of dopamine and norepinephrine, effectively increasing the concentration of these neurotransmitters in the synaptic cleft. It also appears to act as a non-competitive antagonist at certain nicotinic acetylcholine receptors.
So by elevating baseline dopamine and norepinephrine, it artificially provides some of the reward and stimulation the brain expects from smoking, which blunts the severity of the withdrawal symptoms and significantly reduces cravings.
That is the clinical effect. However, the mechanism demands careful clinical reasoning regarding contraindications. Because bupropion increases noradrenergic and dopaminergic activity, it inherently lowers the physiological seizure threshold in the brain. Therefore, it is strictly contraindicated in any patient with a known seizure disorder.
I also read that it is strictly contraindicated in patients with a current or prior diagnosis of an eating disorder, such as anorexia nervosa or bulimia nervosa. At first glance, that seemed like an unusual connection. Why does an eating disorder preclude the use of this specific cessation medication?
It comes down to compounding physiological vulnerabilities. Patients with severe eating disorders, particularly those involving purging behaviors or severe caloric restriction, frequently suffer from chronic electrolyte imbalances, most notably hypokalemia or low potassium, as well as metabolic disturbances.
Okay, so their baseline is already fragile.
These systemic imbalances inherently lower the brain seizure threshold on their own. If you introduce a medication like bupropion, which also lowers the seizure threshold, into a neurobiological environment already destabilized by electrolyte depletion, the cumulative risk of a severe, unprovoked seizure becomes unacceptably high. It is a perfect example of why a psychiatrist must treat the whole patient, not just the isolated addiction.
That is fascinating. It requires a truly holistic understanding of the patient's medical history. This brings us to the heavyweight champion of cessation pharmacotherapy, varenicline. The pharmacology of this drug is a masterpiece of targeted drug design. If we return to our lock and key analogy for the receptors, varenicline operates as a highly specific skeleton key.
Skeleton key is an excellent conceptual bridge to the pharmacological term, which is a partial agonist. Varenicline was synthetically engineered to target the exact nicotinic receptor subtype responsible for nicotine addiction, the alpha-4 beta-2 receptor.
So it fits perfectly into the specific lock. And because it is a partial agonist, it turns the lock just slightly. It doesn't throw the door wide open like full nicotine does, but it opens it enough to initiate a low, steady trickle of dopamine release in the VTA.
Right, a controlled release.
And this trickle is sufficient to satisfy the upregulated receptors, effectively turning off the blaring alarm of the habenula and completely suppressing the physical withdrawal symptoms and cravings.
That is the agonist property at work. But the true genius of varenicline is its incredibly high binding affinity for that receptor. It binds to the alpha-4 beta-2 receptor more tightly than nicotine itself. So while the skeleton key is sitting in the lock, providing that low dopamine trickle, it is physically blocking the keyhole.
It prevents the real key from entering. This is the antagonist property. If a patient is taking varenicline, experiences a moment of weakness, and smokes a cigarette, the nicotine rushes to the brain in 15 seconds. But it finds all the receptors already occupied by the varenicline. The nicotine cannot bind. Therefore, the patient does not experience the massive, rewarding dopamine spike they were anticipating.
It just doesn't work.
The cigarette suddenly feels useless and unrewarding. It chemically breaks the classical conditioning loop while simultaneously treating the physical withdrawal.
It is an incredibly powerful dual mechanism. Unsurprisingly, extensive clinical data demonstrates that varenicline is the single most effective monotherapy for achieving long-term smoking abstinence. However, despite its efficacy, the use of varenicline, particularly within the psychiatric community, was severely hampered for years by a cloud of significant controversy and fear.
You are referring to the FDA black box warning.
Yes. Shortly after varenicline was brought to market, post-marketing surveillance reports began to emerge, suggesting a potential association between the medication and severe neuropsychiatric adverse events. There were case reports of patients experiencing newly onset depression, severe agitation, psychosis, and suicidal ideation while taking the drug.
That sounds terrifying for a prescriber.
And given that smoking rates are highest among patients who already suffer from these exact psychiatric vulnerabilities, the FDA placed their most stringent warning, a black box warning, on both varenicline and bupropion.
That must have created a massive clinical paralysis. You have the most effective tool to treat the deadliest disease your patients face, but the regulatory body is warning you that the tool might cause them to become suicidal. How did the psychiatric community navigate that?
It resulted in widespread underprescribing. Clinicians were understandably terrified of destabilizing their fragile patients. The field desperately needed rigorous, large-scale, controlled data to determine if the medication was actually causing these events, or if the symptoms were simply the natural consequence of severe nicotine withdrawal in a vulnerable population.
Right. Correlation versus causation.
Exactly. This brings us to one of the most important clinical trials discussed in the textbook, the EAGLES trial, published in 2016. EAGLES stands for Evaluating Adverse Events in a Global Smoking Cessation Study.
The scale and design of this trial are breathtaking. Walk us through how they structured it to finally answer this question.
It was a monumental, landscape-altering piece of research. It involved over 8,100 participants across 16 different countries. Crucially, the researchers intentionally split the participants into two massive cohorts. One cohort of smokers with no history of psychiatric illness, and a second, equally large cohort of smokers who had established stable psychiatric diagnoses, including major depressive disorder, bipolar disorder, anxiety disorders, and schizophrenia.
They intentionally tested the drug on the exact population everyone was terrified to treat.
Precisely. They rigorously randomized both cohorts into 4 treatment arms: varenicline, bupropion, the nicotine patch, and a placebo pill. They then meticulously tracked every participant for moderate to severe neuropsychiatric adverse events, such as agitation, hostility, depression, and suicidality.
And what were the definitive findings? Did the medications cause a spike in psychiatric decompensation?
The findings were definitive and practice-changing. The EAGLES trial conclusively proved that the incidence of moderate to severe neuropsychiatric adverse events was not significantly higher in the patients taking varenicline or bupropion compared to those taking the nicotine patch or the placebo.
So the medications did not cause the psychiatric crises?
They did not. Now, unsurprisingly, the cohort with pre-existing psychiatric illnesses experienced more adverse events overall than the non-psychiatric cohort, regardless of which treatment arm they were in. Quitting smoking is inherently stressful.
Sure, the baseline risk is higher.
Right. But the medications themselves did not elevate that baseline risk. Furthermore, the trial confirmed the efficacy data. Varenicline was superior to bupropion, the patch, and placebo in helping patients achieve continuous abstinence in both cohorts.
The data was so robust and irrefutable that the FDA took a highly unusual step.
They did. Based on the strength of the EVIL's data, the FDA officially removed the black box warning for neuropsychiatric adverse events from both varenicline and bupropion. It was a massive liberation for clinicians. The data unequivocally states that the risk of a patient dying from a tobacco-related illness astronomically outweighs the risk of experiencing a severe psychiatric side effect from the cessation medication.
Which means
Psychiatrists no longer have an evidence-based excuse to avoid using the most effective tools in their arsenal to save their patients' lives.
to really synthesize all of this complex neurobiology, pharmacology, and clinical reasoning, I want to walk through a specific case study provided in the textbook, because it beautifully models how a modern evidence-based psychiatrist should approach this.
Yes, the case of Ms. H.
Right. Let us look at the case of Mrs. H. She is a 45-year-old patient with a long-standing diagnosis of schizophrenia. She smokes 35 cigarettes a day, nearly 2 packs, and she has been smoking since she was 20 years old, right around the time of her first major psychotic break.
And the most tragic yet common detail of her history is that for 25 years, throughout dozens of psychiatric admissions and outpatient appointments, not a single psychiatrist ever formally advised her to stop smoking.
Not one.
No. They all operated under the great misconception, assuming she couldn't quit or that the stress would worsen her schizophrenia.
Her addiction was entirely ignored by the mental health system. Eventually, her primary care physician strongly recommends she quit because she has developed asthma and early-stage cardiovascular disease. So she tries to quit cold turkey, relying on willpower alone.
Which rarely works.
She fails within 48 hours because her withdrawal is excruciating, and she lives in a group home where all her housemates chain smoke indoors. The environmental cues are just overwhelming. So she presents to her psychiatrist for a routine medication management appointment, and she mentions her failed attempt. What does this modern psychiatrist do?
They immediately employ the 5 A's. They ask about her current smoking volume. They advise her clearly that quitting is the best thing she can do for her heart and her lungs, and crucially, they validate her capacity to succeed. Then they employ a brilliant motivational tool. They have Mrs. H breathe into a carbon monoxide meter right there in the clinic.
The meter shows her a highly elevated number, objectively demonstrating the carbon monoxide displacing the oxygen in her red blood cells.
It takes the abstract concept of lung damage and turns it into a concrete, visible, undeniable number on a screen. It's a powerful catalyst for motivation. They then assess her readiness. She is highly motivated, so they move to assist.
And they recognize the environmental trap of the group home. They don't just prescribe a pill, they help her arrange for her housemates to agree not to smoke in the common areas, creating a slightly safer environment.
That's proactive care.
They then prescribe a combination NRT strategy, a long-acting nicotine patch to manage the baseline alpha-4 beta-2 receptor demand, and nicotine gum to handle the acute cravings triggered by her housemates.
And they arrange close follow-up. They have her call the clinic 2 days after her quit date to check on her withdrawal symptoms and ensure her schizophrenia remains stable. However, a week later, she returns to the clinic. She managed to abstain for 4 entire days, but then the stress of an argument triggered a massive craving, and she relapsed. She is smoking again.
This is the moment where historical psychiatric approaches often failed, leaning into judgment or viewing the relapse as a failure of compliance. But this clinician demonstrates profound empathy and clinical skill. They do not shame her.
Exactly. They reframe the narrative entirely. They explicitly praise her for the 4 days she managed not to smoke. They validate the immense neurobiological effort it took to fight 1.5 million conditioned responses for 96 hours. They normalize the relapse, reminding her that tobacco use disorder is a chronic relapsing brain disease and that most successful quitters require multiple attempts.
So they let the dust settle. 2 months later, they try again. But this time, they escalate the intervention. They use an iterative clinical approach.
They increase the psychosocial scaffolding. They enroll her in a dedicated smoking cessation support group. They involve her boyfriend in the plan to provide external accountability. And they arrange for clinic nurses to provide frequent, encouraging check-ins.
And they adjust the pharmacotherapy based on the previous failure. They combine a nicotine patch for baseline control, a nicotine inhaler to satisfy the behavioral hand-to-mouth fixation, and they add bupropion to elevate her baseline dopamine and further blunt the withdrawal.
It is a masterclass in comprehensive psychiatric care. They treat the neurobiology, they modify the environment, they manage the psychology of failure, and they relentlessly support the patient. They treat the addiction with the exact same rigor and clinical intensity that they apply to our schizophrenia.
We have covered a massive expanse of clinical territory today. To ensure these critical concepts are consolidated, let us transition into our learning reinforcement phase. I am going to present 5 single best answer style questions drawn strictly from the mechanisms and data we have discussed from the textbook. I will read the question and I encourage you, the listener, to pause and formulate the precise answer and the underlying rationale in your mind. Then our expert will reveal the answer and elucidate the clinical meaning. Are you ready? Let us begin. Question 1. We discussed the profound pharmacokinetic interactions between tobacco and psychiatric medications. Which specific hepatic enzyme is induced by the polycyclic aromatic hydrocarbons present in tobacco smoke, leading to potentially dangerous spikes in blood plasma levels of medications like clozapine and olanzapine upon sudden smoking cessation? Think about it for a second. So, what is the answer?
The correct answer is CYP1A2. The clinical reasoning here is paramount. Quitting smoking abruptly removes the induction of the CYP1A2 enzyme, rapidly slowing down the liver's metabolism of these specific drugs. If the psychiatrist does not preemptively reduce the prescribed doses, the patient can experience severe medication toxicity, which can manifest as profound sedation or severe akathisia, often mimicking acute psychiatric deterioration.
Excellent. Question 2. Moving to the etiology at the microscopic level. Which specific subtypes of the ligand-gated nicotinic acetylcholine receptors are primarily implicated in the reinforcing rewarding properties of nicotine and subsequently undergo massive upregulation in response to chronic exposure? Take a moment. What are those receptors?
The answer is the alpha-4 beta-2 and the alpha-7 receptor subtypes. Comprehending these specific receptor targets is vital because they are the precise locus of the pathology, and they are the exact pharmacological targets of our most sophisticated and effective cessation pharmacotherapies, such as varenicline.
Spot on. Question 3. We explored the shifting regulatory landscape of cessation medications. Which major multinational 2016 clinical trial provided the definitive safety data that led the FDA to remove the black box warning for severe neuropsychiatric adverse events associated with varenicline and bupropion? Any guesses?
That was the EGLAS's trial. By rigorously studying over 8,000 participants, including a massive cohort with stable pre-existing severe mental illnesses, it conclusively proved that these medications do not significantly elevate the risk of severe psychiatric adverse events relative to a placebo. This trial removed a massive fear-based barrier to providing life-saving treatment to the psychiatric population.
Question 4. Examining the evolution of the diagnostic manual. According to the DSM-5 criteria for tobacco use disorder, why were the specific physiological symptoms of reduced heart rate and weight gain removed from the formal diagnostic criteria for nicotine withdrawal, despite being common physiological realities? Think back to our discussion on the DSM.
They were removed because extensive research demonstrated that these two specific variables possess no predictive validity regarding smoking cessation outcomes. While they are physiological facts, they do not clinically drive the pathology or predict whether a patient will relapse, unlike symptoms such as intense craving, depressed mood, or severe anxiety. The DSM-5 streamlined the criteria to focus on symptoms that directly impact clinical outcomes.
And finally, question 5. Addressing the legacy of the great misconception. According to the definitive 2014 systematic review and meta-analysis conducted by Taylor and colleagues, what is the actual documented long-term impact of smoking cessation on the psychological well-being of patients with psychiatric comorbidities? Let's hear it.
The documented impact is a significant sustained decrease in anxiety, depression, and psychological stress, alongside marked improvements in overall mood. Quitting smoking does not destabilize long-term mental health. It fundamentally improves it, often allowing patients to maintain psychiatric stability on lower dosages of psychotropic medications due to the removal of the chronic neurochemical stress of withdrawal.
A brilliant synthesis. For the listener, we highly recommend returning to Chapter 11.8 in Kaplan and Sadok to review these mechanisms and trials with the text right in front of you. As we conclude our investigation today, I want to leave you with a provocative thought that builds upon the foundational mechanisms we have explored. We have thoroughly dismantled the mystery of why humanity steps into the traditional combustible trap of the cigarette and how the industry historically exploited psychiatric vulnerabilities using the fabricated self-medication hypothesis. But the landscape of tobacco use disorder is not static. It is evolving with terrifying speed.
It really is.
As traditional combustible cigarette use drops, we are witnessing the aggressive, ubiquitous marketing of ENES e-cigarettes, delivering highly concentrated nicotine salts directly to the developing brains of a new generation. We are watching adolescents, burdened by skyrocketing cultural rates of anxiety, depression, and psychological distress, turning to these high-concentration devices to self-soothe. If the tobacco industry of the 20th century has successfully used the self-medication hypothesis to convince patients with severe schizophrenia that they needed a combustible cigarette to function, we must critically ask ourselves, how are they framing vaping for modern anxieties?
It's the same playbook.
Exactly. Are we simply watching the exact same neurobiological Trojan horse being wheeled into a new generation city, just painted with sleek, modern digital colors and flavored like fruit? The delivery system has evolved, but the alpha-4 beta-2 receptors remain identical. It is a frontier that every clinician must be acutely prepared to navigate because the consequences of ignoring it will echo for decades.
It is the next manifestation of the epidemic, and we are armed with the neurobiological understanding to confront it. We must ensure that the clinical blind spots of the past do not obscure our vision of the present.
Here are the details of this episode.
Tobacco-related disorders.
Chapter 11.8, Tobacco-related disorders.